Hello, everyone. Thank you for joining us today for DocTalks. I know many of you are invested in the work of Providence, and I'm delighted I can be with you today. My name is Tom Maher, and I'm the branch director for the Portland offices of RBC Wealth Management. RBC Wealth Management is excited to sponsor today's DocTalk. For those of you that don't know, RBC Wealth Management is part of the Royal Bank of Canada. Here in the United States, RBC Wealth Management has become one of the largest wealth managers in the country. We provide our clients with the full breadth of financial products and services. Our local offices are located in downtown Portland, and we have a new office opening up in Lake Oswego. We know that you are committed to your long-term health. Falls are the leading cause of injuries for people over the age of 65. Even falls without injury can cause older adults to become more fearful, making it difficult for them to stay active. Today, I have the honor to introduce Dr. Colleen Casey. Dr. Casey is an associate clinical director in the Providence Senior Health Program. Dr. Casey's job involves identifying ways to improve care of older adults with a focus on an effort to reduce fall risks. She helps advance initiatives that equip providers with clinical tools, education, and support to best care for older patients. She's recognized nationally for her work. Now let's welcome Dr. Colleen Casey.
Thank you, Tom. Good afternoon, everyone. Thank you for sharing your lunchtime with me. I wish we could have lunch together or at least be in the same room. I'm so grateful to be here today. I'm especially appreciative of Lori Sweeney and Kelly Beekler with the foundation, who have worked tirelessly on behalf of senior health. And of course, to Hallie Gentry, who's orchestrated all the details behind the scene. And I'm always grateful to my colleagues in our senior health team, especially my mentor and our medical director, Dr. Marian Hodges. As Tom described, I am a geriatric nurse practitioner, and I have my Ph.D. in geriatrics, specifically around mobility. I've worked in this field that I love for over 25 years, first as a certified nurse's aide at a Montana hospice, where I helped care for hospice patients. As a young person straight out of college with my bachelor's degree and doing a year of volunteer work, I was surprised that many of my hospice patients were actually quite active and moving and wanted to take walks or go out for a ride in the car until even just a few weeks or days before they died. I also bring personal experience around aging. I had aging parents at a young age. Without revealing my own age, my parents now would be over 100 years old. They're now both deceased, but I witnessed firsthand as a daughter caring for my mom over many years how a fall can tip off a spiral of decline that can lead to years of suffering. While I'm going to talk about falls and fall risk today, what I really want to do is introduce a new way of thinking about falls and to shift the first part of our conversation about how we might take a better approach or have a new mindset to help us stay well, actually, focusing on being active and hopefully avoid most of falls in the process. This quote is one of my favorites. Older people don't need to take a pill, they need to take a walk. Walter Bortz, the 91-year-old geriatrician, he's a bit of a hero of mine. He started running in his 40s to deal with the grief from his father's death, and he ended up running over 40 marathons. I had a chance to hear him speak at a Healthy Aging Summit back in 2012, and I've always remembered quite a few of his wise words. He's written numerous books on healthy aging, and he's a real believer of taking aging back into our own hands with less reliance on pills and procedures. This is the very heart of what we do in geriatrics. When we talk about falls or some of the things that can cause falls, like muscle weakness, dizziness, lots of medications, our society most often assumes that falling is just a normal part of aging. Well, if you take only one thing from me today, please remember that falls are not necessarily a part of normal aging. There are a few qualifiers, and I'll get to those a little later, but for most people in their 60s, 70s, and even 80s and 90s, falls do not need to be a part of their normal aging process. And if someone is falling, we need to be paying attention to that. So it's no mystery that the more active and fit and less frail you are, the less risk of falling you have. In fact, one of the under-recognized effects of this pandemic has been the decline in physical activity for adults, especially older adults. My colleagues and I are seeing this all over the place in terms of people not doing as well physically or emotionally. We just were not meant to be as sedentary as we've become during this pandemic. So while I'll be spending quite a bit of time talking with you about falls and fall risk, I want us to keep this bigger notion in the back of our minds that falling doesn't have to be the norm, and that we can all do a better job of embracing more activity and mobility in our lives. And for those of us watching that may be more in the lines of their 40s and 50s, this is the trajectory where we need to adopt more active lifestyles so that we can age as healthfully as possible. To help set the stage, I want to introduce you to this age-friendly framework. Some of you may have heard about this framework from Dr. Hodges and Kelly Piekler at a previous talk. Our team has done a lot of great work around this age-friendly health framework. I can't spend a lot of time talking about it today, but it's a movement started back in 2016 and has what we call the 4M Foundation. You can see here in the green circles: mobility, mentation, medication, and what matters. This is the framework designed by national leaders in geriatrics to answer the question, if we, meaning our healthcare system or any organization, were going to provide good care to older adults, what would it include? So let me briefly describe them. Mobility, which we'll focus on today, you can see. But, and this is very important, in an age-friendly framework, you can see that it doesn't say falls. Mobility does not mean falls or no falls. The emphasis really is on what Dr. Bortz reminded us on the first slide, the importance of function to health and to quality of life. We're focusing on the person's ability to be independent, and in the process, paying attention certainly to fall risk and trying to reduce that risk. The other M's come into play related to mobility. So in a very real way for most people, Hallie, can you advance to the 4M slide, please? These age-friendly M's are intertwined. Medication, we're talking about high-risk meds. Does someone still need to be on medication, or could the dose be decreased or stopped? For mentation, we're talking about several conditions more common in seniors than in younger adults: dementia, Alzheimer's, delirium, depression, and anxiety. We, as healthcare providers, want to be on alert if there's an issue, and we want to manage these areas actively. We're learning more and more about even the connection between cognition and walking. For example, you might be surprised to know that changes in gait, how someone walks, can precede any changes in cognition by up to 5 years. And last but not least, what matters, meaning in addition to any advanced directive, we know what matters and gives meaning to someone. In the case of mobility, what makes them want to be as mobile as possible, or what prevents them from making this a priority. We have found that in our senior health work, that everyone resonates with the 4Ms. Everyone gets that these are the 4 big, tricky, important issues that distinguish how care for older adults is different from younger people. The 4Ms have become a powerful tool for us because we know that if we do well in these 4 big areas as we care for older adults, then we will be delivering better and more age-friendly care. To talk more specifically about falls as part of mobility, let's start with the definition of what is a fall. The World Health Organization defines it as an event that results in a person coming to rest inadvertently on the ground or floor or other lower level. So this means that if you get up from a chair, but you can't quite get to standing and you sit back down again, or you're running up the stairs and your foot slips off the stair and you catch yourself with your hand, this is officially a fall. Any movement that is lower and isn't intentional. Based on these definitions, you can see that Oregon here in these pictures is in deep charcoal, and that is not good. We're ranked in the lowest realm relative to the rest of the country for having the highest percentage of seniors reporting a fall and getting injured, upwards of 30%. This data you see is from 2014, but we still maintain this distinction even in current data. And unfortunately, very perplexing to people like me, we don't know exactly why Oregon distinguishes itself in this way. These national figures boil down to what kind of an issue falls is at a personal level. Next slide, please. The Center for Disease Control and Prevention does quite a bit of work on falls through a program called STEADY, and you can see it stands for Stopping Elderly Accidents, Deaths, and Injuries. The CDC cares about falls because they see falls as a major public health issue for people 65 and older. And while this slide says every 20 minutes, someone 65 and older falls, it's actually now about every 17 minutes that someone dies of a fall who is 65 or older. This means that 84 older adults die each day from a fall across the country. And this is in the same range of deaths per day from something like prescription drug overdoses that gets a lot of well-deserved media attention, but you can see that falls doesn't get as much attention. Who is falling? Well, generally speaking, about 1 in 4 adults fall in the population of community dwelling seniors. And when someone needs more care or lives in a higher supportive environment, like a nursing home, the more care they need, then that percentage goes up to more like 40 to 50%. Why does falling even once in a year matter? Well, because falling even once doubles your chance of falling again. And with every fall comes that risk of injury, of hip fractures. Most hip fractures are caused by falls, as well as head injuries, or even something a little less serious like a sprained ankle. It also leads to more fear of falling, which can then go on to increase falls. So let's pause and take some of these numbers to heart. I want you to think about a group of your friends or family members, or in some sort of a faith or social community that you're part of, who are 65 years or older. Think of about 12 friends, or if you can't think of 12, think of 4 friends. In that larger group of 12, about 3 of them will fall in the next year, and 1 of them will suffer a serious injury that sidelines them for weeks to months. In that smaller group of 4, even 1 of them will fall and potentially suffer an injury. So this matters, right? It hits close to home, and it matters to both you and to your circles that you belong to. The CDC normally cares about epidemics from infections like COVID, of course, but they care about falls too, because they see falls as an epidemic. So my title slide, where I called falls the silent epidemic, I called it that because over many years of working in this arena, I've worked with many, many people who fall. And surprisingly or not, I've actually met very few people who want to talk with me about it. And they especially don't like talking about it with their primary care provider or a medical professional, or even their family. So you can see here, only 1 in 4 people who do fall will go on to talk about the fall with someone. I've come to understand and appreciate that this is an important part of our work. We have to understand why this is. I'll share my working theory by going back to the M of mobility and connect it to why people don't like talking about falls. Falls threaten mobility. They may not know that anything can be done about it. And from that threat, people run the risk of decreasing their function and potentially losing some of their independence. I've learned from patients I've cared for that many of them are fearful of falling. I know that I fell back in the spring and I was fearful for a few more months. They're worried about losing their dignity if they need physical care after a serious fall. They're worried that their living situation may need to change if a fall translates into an injury that means they can't live where they want to live any longer. And they are most worried about losing their independent sense of themselves. This is what matters most to all of us, our independence, right? So my call to arms to you today is that we need to be talking about falls more, much more, because there are actually many things we can do to reduce people's fall risk to fall, but we can't reduce our fall risk if we don't talk about it more openly. We need to reframe this issue of falls much earlier on so that falls isn't normalized as part of aging. And so that if you mention a fall, you'll be met with a serious, let's talk about this, let's address this, rather than, oh, that's just part of getting older, the latter of which potentially threatens your cherished independence. The other reason we need to be talking about falls is because, as you may or may not know, there is a shortage of people like myself and Dr. Hodges who are trained in geriatrics. In fact, within Providence, Oregon, the Providence Medical Group, who are our primary care providers, we serve over 80,000 patients 65 and older each year, and yet we have only 3 trained primary care providers who are trained in geriatrics. This is not just a Providence problem, it's a nationwide shortage due to higher cost of schooling, lower pay for geriatricians, lower reimbursement rates due to Medicare. And let's face it, the ageism in our society has meant it's not considered all that glamorous to serve older people. This larger issue is one that we are actively working on to help lift our primary care providers up as well as their teams. We are leading work through things like our geriatric mini fellowship, which is a 4-week training program for primary care providers within Providence to learn how to care for older adults in a new and better way as they age. We also focus on working with their frontline clinical teams to help them know more of what they need to know and have the skills to have better care for people who fall or who are at risk to fall. So now to your part. This also means that each one of us, each one of you, needs to take matters into your own hands if you haven't already, to reduce your own fall risk. Many of the things our team regularly advises, I talk about this every day, to reduce fall risk, they're not fancy procedures or elaborate medications. If anything, it's just the opposite. Many fall reducing strategies are about common sense, practical solutions, and a willingness to change some of our ingrained behaviors. Granted, changing behaviors is not easy, but it often doesn't cost any money or not a lot of money, certainly cheaper than a hospital bill. And I recommend that everyone take a look at their fall risk factors at least once a year and then plan accordingly. This year of COVID has really wreaked havoc on the activity levels of older people, especially those that were sort of borderline sedentary to start. And now I and my colleagues are seeing dramatic changes in the function and independence level of some of these folks that we work with because of how inactive people have become. Before we talk about solutions, let's talk about what puts you at risk to fall. Please notice that there are twice as many changeable risk factors on the left side as there are risk factors that we can change. We'll talk in more detail about most all of these areas on the left, but this couple greeting you at their front door can, with a little guidance, take a look at many of their risk factors and understand if they need to make improvements. You can see that the woman already is working with a walking aid. And so in this case, this walker is actually helping her to be more independent rather than become more dependent on either her spouse or someone else. And even things like chronic conditions, high blood pressure, diabetes, these can often be improved with healthy lifestyle changes along with good support from your medical team. Again, if you take nothing else from me today, please leave believing that you can do something to improve your risk or your loved one's risk of falling, and that falls are not just part of the normal aging process. Let's talk about all the things we can do to reduce our fall risk. First and foremost, get moving and stay moving. This is an area I love talking about. It's taken me years to get into my own groove, and there's plenty of weeks when I fall off the wagon. But Dr. Bortz is right. Please take a walk versus a medication whenever possible. The national recommendations are for 150 minutes per week of aerobic or endurance activity. And this stands true for seniors as well. So this equates to 5 days for 30 minutes each, but it can also be broken down into 10-minute increments or over 7 days or any combination. And some people may really only be able to start at 10 minutes a day if they haven't been active. You definitely would not want to start overdoing it from the gate. I'm curious what you all think might be the percentage of people 65 plus who meet this national recommendation. So what percentage of the 65 plus population achieve meeting the recommendation of endurance as well as strength and balance each week? I wish we could be together so that I can see your response, but go ahead and feel free to put it in the chat, and then Lori will clue me in a few minutes. So this type of movement and activity is especially important, whether it's walking, swimming, biking, gardening, any number of movement activities. And after age 50, there's a 10-fold difference in mortality that's due to lack of fitness. So there's no reason not to start a program at age 50 or after age 50 because it can make a real difference. And they believe that it makes more of a difference even for people who have been unfit before turning 50. But walking is not enough. After age 50, we lose muscle mass that accelerates by about 2% per year, muscle and bone mass. So to offset this loss and maintain and improve our brain's balancing system, which is a very complicated system, we must do strengthening balance work also at least 2 days a week. These doses of exercise should be consistent, meaning most weeks, and progressive, meaning not always the same old thing each time. So mixing it up a bit for a minimum of 12 to 16 weeks. In fact, in the Tai Chi literature, you can see here they're doing chair Tai Chi. The effect dose was achieved at 24 weeks. So granted, 4 to 6 weeks is a long time, which is intentionally working on behavior change and improving our habits. That's where that really comes into play, is how can you build something that will last for months at a time. Okay, Lori, can you tell me what you have in terms of people's responses?
Yes, because I know you can't see the chat easily. In the lower ranges of percentages, so 5%, 10%, 15%.
Okay, well, you are all realists among me, so congratulations. So the accurate percentage is 8% of people 65 and older actually meet this recommendation. So we've got some work to do. We especially like to talk about Tai Chi. After 24 weeks, as I mentioned, Tai Chi Moving for Better Balance, which is a model out of Oregon State here a homegrown model, showed that Tai Chi not only improves balance, but it reduces the likelihood of falling by about 50%. It also improves strength and flexibility, as well as even aerobic capacity. And on top of that, it's been shown to reduce symptoms of depression, anxiety, improvements in arthritis, and even Parkinson's disease. And there's a growing body of research of Tai Chi in people who have cognitive impairment and dementia. Tai Chi is offered at many senior centers and community centers and is now offered online through various portals, including through Providence. So the foundation website where you linked into the class will have a handout specific to Tai Chi, as well as some other strength and balance options. Certainly, the best exercise for you is the one that you will do. So maybe Tai Chi is not it, but you like yoga or Pilates or some other strengthening program. Make it work for you. And if you aren't active, walk more through the house, do chair stands up and down from your chair. If you are active, add on the stairs if you don't already. Make small steps and be intentional over time. If you are brand new to exercise, or you've had an injury, or you need modifications to create a routine that works for you, please consider seeing a physical therapist. We have 30 rehab clinics throughout Oregon that can help be part of this process, and just ask your primary care provider for a referral. When it comes to what especially matters to older adults, the evidence is very strong that most people want to make their current living situation work, if at all possible. In fact, these National Council on Aging numbers show us that most people live in the same home they've lived in for years, and they intend to stay there. Unfortunately, sometimes it takes a fall and a major injury that leads someone to have to be forced to move, which is not something we ever want to see. The majority of people are willing to have modifications and some additional help, which can help extend the time to keep people living in the home environment they want to be in. So the safety of their home environment then becomes especially important, in addition to staying strong and staying healthy. There are certain design features of aging in place, like higher countertops and toilets, lighting that goes on automatically with motion. And then there can be formal assessments done by someone like a physical or occupational therapist that can identify areas of concern. So these formal studies have been what's used in the research to show that fall risk can be reduced by about 1/3 if the interventions that they recommend are adopted. So what are some of these interventions? even if we don't have an occupational or physical therapist at our disposal, or we choose to do it on our own, we can do our own home safety assessments. And this is especially important during the pandemic when we've all been spending so much time at home. For example, in this gentleman's living room, we would want to make sure that the cords to his recording equipment are tucked away and he's not going to trip on them, that he's able to navigate around the couch easily enough to be able to get to the books on the bookshelf, and that even the couch height is appropriate for him to get up and down safely. Those are just the things that we can see in the picture. The link to the home safety checklist that you can find off the foundation website goes room by room to help you take a look and identify different areas. And then of course, our fall risk class goes into even more detail. In our own homes, we want to make sure that, oh, can you go back, Hallie, please? In our own homes, we want to make sure that we don't have a lot of clutter around, that throw rugs don't have the lips of them peeled up, or that we use nonstick tape or double-sided tape, I should say, on the end of the throw rug, that there's handrails where they're needed, as well as night lights, perhaps at the bottom of a dark stairwell. I know that I always travel with a night light to make sure that if it's a foreign environment that I can see appropriately. And then if you have pets, which so many people do, making sure that at the end of the day, the toys are out of the way, that we don't have a pet bed laying in the common pathway. And then for folks as they age, particularly in their 70s and 80s, asking a friend or a family member to take on those tasks that might require certainly ladders and sometimes step stools, or at the very least, making sure that they're safe to use. If you have any change in health condition, or particularly are coming out of having been sick, for example, being in the hospital, making sure that you have a home safety lens and that you're looking at your environment with any change in your condition. Please make sure that you listen to that voice in your head. Those voices in our head are really powerful. If it's telling you probably you shouldn't be doing something, you shouldn't be doing something. And if you go ahead and do it, have a safety plan so that the people you know or who know you have lists of emergency numbers and contacts. And of course, now there's technology like fancy watches that can even track falls for us. Next slide, please. Just some last tips. It's important to know that the older adult who goes barefoot or wears flip-flops or only socks falls quite a bit more. And so we really promote wearing comfortable, good-fitting shoes that definitely have a back. So even slippers would have a back, as well as a good sole that doesn't slide around on the floor. Making sure that even in the house, you would be wearing some sort of a decent shoe within the house, maybe a dedicated pair of shoes just for the house. And if you do have any structural issues going on with your foot, any neuropathy or any pain, certainly ask for a referral to see a podiatrist. As far as vision goes, staying on top of your vision, I can't tell you how many times we see people's eyeglasses, including my own sometimes, that are so dirty. So making sure that you're cleaning glasses regularly. You can see this picture. I'm not sure if you can identify it, but this is a man holding a pair of glasses. This is actually a patient of mine who I saw, and his glasses are literally taped together with Scotch tape. So certainly he needs a new pair of glasses, or at the very least, it's probably better off not wearing these glasses. Please wear sunglasses to reduce glare, and just be aware that changing environments in a sunny, during a sunny day, that you're gonna really need your eyes to acclimate. If you're very active and doing a lot of outdoor activity, but wear bifocals, there's some good evidence to suggest that switching to wear single distance lenses when you're outdoors can help navigate curb cuts and that sort of thing better, and then saving your bifocals for indoor use. All right, last but certainly not least, let's discuss high-risk medications. This is a really big issue, not just related to falls, but certainly affects fall risk as well, because almost a third of the emergency room visits are due to drug-related causes. And this isn't because people are inappropriately taking medications. Most often it's because people are taking a lot of medications, and many of them can interact with each other, or they end up on doses of medications that no longer become appropriate for them. So this is a really serious issue. It's a premise of geriatric medicine to avoid medication if at all possible, and to use things like stretching, ice, heat, or any topical creams, that sort of thing. Of course, we do use medications when we need to, But again, there are lists of age-appropriate medication, age-friendly medications, I should say, as well as lists of medications to avoid that are not considered age-friendly. So making sure that your healthcare team is aware of these lists. And if you are needing to be on a high-risk medication, that the dose used is the smallest dose possible and used for the least amount of time. And we have excellent pharmacists in our Providence system. We also have a brand new geriatric pharmacy residency that work is led by Sharon Lee, who's one of our senior health pharmacists, our lead senior health pharmacist. So there's a lot of good work being done around keeping people safe relative to high-risk medications. I only have time to mention two medications in particular. One is to avoid and one is to adopt. So I want to point out to you that Benadryl or diphenhydramine is commonly available over the counter, and it's in many, many products. You might see Tylenol PM or Advil PM. I feel like I see a new PM product every time I go to the store. So as people age, Benadryl can really wreak havoc on their cognition. It can cause falls, can cause disorientation. And so making sure that you avoid Benadryl at all costs. And if you need allergy medication, you can use a safer alternative after talking to your doctor. In terms of vitamin D, this is something that we would want you to be taking not only for fall risk, but from a perspective of bone health. I'm not talking about bone health specifically today, but it's another aspect of fall risk management that's very important. So making sure that vitamin D in the amounts of about 2,000 to 4,000 units daily is on your radar and that you're doing that each day. That's it. That's all you have to do to reduce your fall risk. No, it's a lot, granted, and maybe more for some of you than for others, but I want you to take just a minute and think about what you will prioritize to reduce your fall risk. Or if you're in the situation where you're helping someone else to reduce their fall risk, what will you emphasize? Where will you put your energy? And then maybe even write that down. We've covered a lot of the key areas. And of course, this can be a longer term process depending on how many risks you might have. But don't just think about what you might do today or tomorrow. If you have a lot of areas to improve on, think about it in terms of weeks or months and make a plan, just like you would for an oil change in your car, to check back in with yourself in a few months. Have an accountability buddy, mark your calendar. That is what you can do to decrease your own fall risk, or like I said, someone who you care about's fall risk. In terms of what you can do, that's what we just described. In terms of what we are doing to prevent falls, reduce fall risk, and then put mobility at the forefront, we have three main areas where we work primarily. First, we've developed a strong series of fall risk talks out in the community, and I'm going to talk about that on the next slide in just a moment. We're also working very closely with our primary care partners and our rehab clinics across Oregon to normalize talking about falls, to promote regular fall risk screening, and then if someone is at risk, to address this risk through fall risk addressed visits. This requires a lot of training and retraining of teams, and I won't sugarcoat it. It's very challenging work. Providers and primary care practices are very busy, and especially now with COVID, they're even busier. But falls are still happening, and sometimes they're happening more right now because of COVID. So it's really important that this clinical condition is paid attention to. We are making strides, though, in this arena. And lastly, we work on projects to help our most frail older adults. In this group, unfortunately, we have certain groups where falling is more common and can be a marker that a person's condition has changed. Certainly, there are conditions where falls happen more commonly, like in a person with Parkinson's. We sometimes then realize we are in a different place. This is when falls deserves a more palliative approach, because our conversation needs to be about what matters to that person towards the end of their life and not strictly on just tackling risk factors. We've been very grateful to the foundation for supporting our work in all three of these areas. I do want to spotlight our community fall risk classes on the next slide, led by my colleague, Jamie Colley, who's a physical therapist and balance expert. Over the last 5 years, we've served over 1,500 people across 14 counties through this 90-minute talk. It's typically taught by a physical therapist as well as by a pharmacist, and people are introduced to Tai Chi by local instructors so they can get a taste of it. We also like to spotlight Ida Keeling who you can see pictured here. She just died at the end of August at the age of 106, and she started running marathons in her 50s and 60s, which is amazing. She's very inspirational. In September, there's a national effort for National Fall Prevention Awareness Week sponsored by the National Council on Aging. So we heavily promote our classes during this time. So it's a perfect month to be talking to you about falls. And you can see here, there's a link on the foundation website to our flyer that will give you additional information. But you can see that the links on the flyer allow you to register online, and these classes are taught virtually currently. We've also been very appreciative to be able to give out over 500 mobility kits because of a generous donor. And these kits have been very popular and include night lights, a lens cloth to clean eyeglasses, as well as flashlights and non-skid socks. In closing, I just want to share my final thoughts on this 4M, the fourth M of mobility. We need to not assume that falling is inevitable. We need to talk more about falls and fall risk. And this is not just in the lay community, but especially in the medical community. And importantly, we need to normalize activity and mobility that comes with aging and expect older adults to move more. We need to expect ourselves to move more as we age. Lastly, we need to recognize that there are many small action steps that we can do on our own to reduce our risk of falling, and take these small steps to be more active and to reduce our risk. Again, thank you so much for your time today. I hope I have left you with a few ideas and perhaps a new way of thinking about your own falls and your mobility, or at least a path towards healthy aging for either you or someone you care about. Our team is always available if you have questions or you want to learn more about our program, and I'm happy to take questions with the time that we have left. Thank you so much.
Thank you, Dr. Casey. That was super informative, and we appreciate the time. And we do have a couple of questions. So I would like to put those questions to you, and we can all learn from these questions that have come up. The first one asked really about bone health. Is there a difference between falling and breaking your hip, or how often is it because of a weakened hip that someone might fall? Can you differentiate between those two instances?
That is a very good question, and we have a very sophisticated audience if they're asking that question out of the gate. So most hip fractures occur because of the fall. So the fall causes the impact that then leads to the hip fracture. There are some cases where, for example, someone may have such brittle hip infrastructure that they break while standing, and then that leads to a fall. But for the most part, a fall generally occurs first and then leads to a hip fracture. And they also call osteoporosis a silent disease as well. So really important that particularly those of us in our 40s, 50s, 60s, that we're really staying on top of our bone health, because that is going to really serve us in the long run.
Yes, I'm 61, and I definitely got the message about vitamin D. So thanks for that reminder. Do all hospital clinics, even like Kaiser, have a rehab pro that can come to homes to do a fall risk assessment? Or can you just give us an update on how those assessments are done?
Those assessments, honestly, can sometimes be tricky to come by. What's a first good step is to start with the home safety checklist that I recommended. The next step would be to, whatever healthcare system you're in, would be to identify who their balance experts are. And usually if you call the rehab clinic and you ask to be seen by someone who specializes in falls or balance, then they will be able to then start the conversation and the exploration of who would be appropriate, hopefully, to be able to do a home safety assessment for you. And I'll just add that the experts in the field of balance and rehab are called neurovestibular experts. So neurovestibular is a big word, but those are specialists with subspecialists within rehab that can really pay attention to your fall risk, and they can make miracles happen relative to people who are unsteady or having dizziness.
Neurovestibular. Okay. I'm not going to try to spell that, but I'll repeat it for everyone. And in that vein, I know you warned against Tylenol, PM, and other drugs that have Benadryl, but is regular Tylenol okay?
Yes, thank you for clarifying. Yes, regular Tylenol is great. We promote it commonly, particularly in our folks who are probably in their 70s and 80s and upwards. Regular Tylenol is in fact cleared by the liver. And so as long as you don't have any liver disease, unlike many medications that are cleared by the kidneys, which also have their own aging process, even if they're healthy kidneys, it's very safe to use Tylenol because of the fact that it's cleared more so by the liver.
That's great.
Just make sure it doesn't have the PM attached to it.
Okay, so the PM is the key word to avoid, it sounds like.
Yeah, and I'll also just add that for anyone that's dealing with ongoing pain, so arthritis pain, for example, which it's normal to have arthritis as someone gets older. If you do have arthritis pain and your occasional Tylenol isn't cutting it, you could try taking that on a more daily basis, because you have to get that amount up to speed in your bloodstream, what we call steady state, so that you can kind of have the pain relieving benefits of it more reliably. So you can take, say, for example, 500 milligrams, 2 to 3 times a day. Again, not distributing personal medical advice, but.
Well, thank you for the added benefit. Whenever we can slip that in, it's nice. And for medicine, are there questions we should ask to evaluate the fall risk with any medication that were prescribed? What would be some suggestions you would have for helping evaluate whether medicine might contribute to a fall?
Yeah, having a sort of annual, as part of your annual fall risk look back, having an annual time where you would take a good look at your medication list. And hopefully many of our Providence clinics and not even, I think, elsewhere in the community have pharmacists associated with their clinics. So they can do a comprehensive medication review. And then also there are certain drug categories. Again, I mentioned those just briefly, things like something called the Beers list, where the Beers list includes sort of the no-no drugs for people as they age. And so that is something that, again, we're training up our teams more and more robustly so that they're more easily identifying those types of medications. But things like sleeping agents, muscle relaxants, benzodiazepines, those are the types of drugs that you would really want to work with your primary care provider to ease off of, so that, and I certainly don't recommend just stopping those. You would want to be doing that in partnership with someone.
Okay, thanks for that, counsel. And do more falls happen around the home or when you're out and about? Do you have a sense of that, or some advice that you might give around, kind of the place where falls happen?
Yeah, good question. The data sort of varies, but generally speaking, the majority of falls do happen around the home. And I think that's in the order of about 60%. And within the home environment, the bathroom and also the kitchen tend to be kind of the major culprits. So it's not unusual, of course, that you would see, particularly if you go into a senior living community, that they might have a lot of their supportive gear in the bathroom setting, because that is where some of the fall risk happens.
Right, you see those fall cords there in the bathroom and that sort of thing. And I know I have put a motion sensitive nightlight in our bathrooms, all of our bathrooms in our hallways. So that just seems, that's really helped, actually.
It does help. And I especially really encourage people, for dark hallways or the bottom of dark stairwells, that you do have something like that, that you're using, because it's just, it makes sense, right? You want to illuminate those areas that are, so that you can see better.
And then we had a question about SOB. Do you know what that is?
Shortness of breath?
Shortness of breath. Okay, great. I didn't know what that. I wonder if it is assumed by most patients that shortness of breath is abnormal and reason to stop aerobic exercise. Could you comment just on people's previous experience with shortness of breath with a health crisis and how that might affect one's, proclivity to do exercise, to get out and move?
Yes, I mean, every exercise program, particularly if you're starting out and if you have chronic conditions, you would want to be tailoring that and working with your medical team to make sure that it's going to be safe for you to do so. And so, for example, there are multiple reasons why someone might have shortness of breath. So identifying, whether that's some sort of uncontrolled or controlled medical reason, or if there is a fair amount of deconditioning, someone can be short of breath because they haven't done any physical activity for months on end. So making sure that you're working with someone so that you can monitor that. And our physical therapy colleagues, when they do endorse aerobic activity, they're really asking folks to not be increasing that activity by more than about 10% per week. So you're not going from 30 minutes to 60 minutes, you're going just incrementally in smaller segments upwards.
Okay, thank you. And then finally, unless there are other questions that you can put in the Q&A icon at the bottom of the screen, the beers list that you referenced, is that something that an ordinary person could look up online, or?
Yes, the beers list is really meant for medical professionals, but my guess is that there is probably a lay version, a consumer version that you could look up. And if you just put in, well, in fact, we would have a good place to start on the foundation website because one of our handouts that is around high-risk medications and its relationship to falling is on that list, is on that website. So you can check that flyer as a starting place as well.
Okay, great, because I wasn't sure if it was spelled beers, which would be sort of amusing with the medication thing. B-E-E-R-S, or is it B-E-H-R-S, or?
It is BERS, and I will, the General Falls talk, which I've been encouraging people to attend, addresses this, but since you mentioned beer, Lori, I will just put in a plug that people do need to monitor their alcohol intake, because alcohol intake in excess of the 1 serving a day for women 65 and older and 2 servings a day for men 65 and older is definitely has become more of a risk factor for falls over the last, I would say 5 or 10 years. And a serving size of wine, for example, is 5 ounces. So I always encourage people to measure out their ounces of what their nightly wine is, just to get a good sense of where they're coming in relative to the World Health Organization recommendation.
Well, thank you. I believe that concludes the questions that we have. And I just wanted to thank you again, Dr. Casey, and also to thank RBC Wealth Management for sponsoring today's Doc Talk. It was really, really informative, Dr. Casey, and I really appreciate both the time preparations that you put in for preparations and the great resources that are available on the Providence Foundation's website. I also wanted to let you know a little bit that as well, that if you're inspired by today's presentation and you would like to get more involved, please feel free to connect with me. My information is on the screen, and we will be sending you a follow-up email in the coming weeks. The presentation has been recorded, and you will get access to that recording in the next couple of days. As well, this is a series, Doc Talks is a series, and our October Doc Talk will be on Thursday, October 21st. And I'm really going to underline Thursday because we have traditionally done these on Tuesday. So this is a Thursday presentation and will feature the Providence Cancer Center. So note this on your calendars, and also know that on the Providence Foundation's website, you can access all of the Doc Talks in a recorded setting. It's really great to be able to catch up on topics that you might be interested in. And again, thank you so much for joining us today. Thank you to RBC, and mostly thank you to Dr. Colleen Casey for doing a wonderful job of educating us about how to prevent falls.
Happy to be here. Thanks for the opportunity, Lori.